All right, guys. Hopefully this will work. I'm probably going to post a few short videos. I've kind of lost my voice a little bit, and I feel like it's finally back enough that I can post a little bit of our lecture. So I'm going to get started, see how far I can make it, and go from there. So we are talking about shock, and there's a few different types of shock that we will focus on. So basically, shock is all four of the different types are going to be unique in some ways, and that's going to be related to the decreased tissue perfusion, and impaired cellular metabolism. So basically, we have this imbalance between the amount of oxygen that the cells need and what we are able to provide. So the four main types of shock that we will discuss are cardiogenic, hypovolemic, disruptive, and obstructive. So we're going to start with cardiogenic shock. Um, so with cardiogenic shock, you can have a systolic or diastolic dysfunction. So with the systolic, the heart is not able to pump the blood forward. So we're going to have low CO2 and cardiac index. And this is mostly going to affect the left ventricle because our systolic pressure is greater on the left side of the heart. The most common cause of this is an MI. And, well, we'll come back to that. For the diastolic dysfunction, you're thinking more about the heart's inability to fill. So, there's a handful of different causes for that one. And I actually think I have these on another slide, so we'll get to that as well. So manifestations of cardiogenic shock. At the beginning, you're going to have a lot of the similar signs to patients with heart failure. You're going to have tachycardia, you're going to have hypotension. You may hear crackles because of pulmonary congestion. And you're going to see a lot of the signs and symptoms of hypoperfusion. So you're going to see the cyanosis, the pallor, you're going to have weak pulses. You might have like the cool, clammy skin. You might see poor cap refill. Um, Basically, the heart can't keep up. The workload is too great for it to really keep up. And so it's your body is smart and it's going to get blood where it needs to go. But you might also see even like anxiety and confusion. You might see as the body, sends blood to the brain instead of to, our kidneys, you might see decreased urine output. So with hypovolemic shock, we are talking about the inadequate fluid volume. So we're talking about that volume that's in the intravascular space, and we don't have enough to adequately perfuse. So in this one, the heart is working fine. It just doesn't have enough of what it needs to actually pump out. So this could be because of like hemorrhage, GI like issues, vomiting, diarrhea, diuresis. That would be those would fall into the category of absolute hypovolemia, which is where you've lost the intravascular fluid volume. You could have like fistulas. There's a lot of different ways that this can manifest, but you also have relative hypovolemia, and that's when you have like the third spacing, where the fluid moves out of the vascular space into the extravascular space. So either way, you're going to have kind of the same consequences of this. So on this next slide here that I'm going to go to in just a second, I kind of put the patho map of what we're seeing here. And so, well, here, let's go to this slide and you can kind of see there's a slightly more complicated one in your book. Well, no, I guess it is the same one. So basically, with both types of this hypovolemia, you're going to decrease volume. Sorry, I'm already losing my voice. So obviously, we're having decreased venous return. We all, we get down to the decreased cardiac output, decreased oxygen supply, and then, of course, we have the decreased tissue perfusion and the impaired cellular metabolism. So this is just kind of a good picture and really just a real good overview and probably basically what you need to know about the patho of hypovolemic shock. There's more to it, but I don't think you need to get into the nitty-gritties of the little stuff. So we're going to leave it at that for now. And we will move on to this next picture that I just thought was a good reminder. So this is just showing us the black arrow where it's pointing. So this is talking about a capillary. And you're seeing how the osmotic pressure and the hydrostatic pressure are related when it comes to the blood flow and the interstitial fluid. So I just thought this was a good graphic to help us kind of picture what is going on with the hypovolemic shock. And wow, I'm struggling today to pick my words. But with the relative hypovolemia and the third spacing and just kind of how all that works. So here's just another picture. I'm really into visuals, so I just thought these graphics were super helpful. Just kind of showing what we just talked about. So you have the reduced intravascular blood volume, which decreases preload. So then you have your reduced stroke volume, which is going to increase your heart rate. It's going to increase your contractibility. You're going to have the vasoconstriction, which is going to lead to those symptoms that we already talked about. So I just really liked that picture. So as far as exactly the manifestations and what that's going to look like, it's going to kind of depend on like the extent of the injury. It's going to depend on how healthy the patient is to begin with. If they already had a bad heart, bad kidney, whatever, it's obviously going to make things quite a bit worse. Patients can compensate for up to 15% loss, but then once you get to the 15 to 30%, you're going to have the SNS mediated responses. You're going to have increased heart rate, CO, increased respiratory rate, maybe even the depth of respirations. And once again, patients might be anxious, urine output's going to start to decrease. So really like correcting the hypovolemia, is your most important thing to think about. You're going to want to, keep an eye on hemoglobin, hematocrit, your electrolytes, blood gases, all that kind of stuff as we start to correct. So we kind of already talked about all this, these manifestations of the hypovolemia. Those pictures are really good to kind of show you what's going on. But if you do better with words, then this is basically the same thing that we just talked about. But just to add, if the loss is greater than 30%, then you're often going to replace with blood volume. There's a good table in your book, table 42.2, I think it is, that has a lot of the common labs and assessments for the hypovolemic shock. So you may want to take a look at that. I won't go over all of it, but some of the things that you might see. All right, just another fun picture that I wanted to add, just to kind of get you thinking of what can cause hypovolemic shock. And, um, it is an emergency. Uh, Bleeding, obviously, from injuries, internal bleeding, is one of the big ones, and it's probably the first one we think of when we think about it. But, you can have fluid loss, like we talked about, from, you know, diarrhea, sweating. One that we didn't mention yet was burns, but that's another one. Severe burns, you're definitely going to see hypovolemic shock. And then just some of the symptoms. So if you're a visual learner, hopefully these pictures will help you. The anxiety, the blue fingers, chest pain, rapid heart rate, shallow breathing, or sometimes you're compensating with deeper breathing, the low urine output. So just a review. Okay, let's see if we can get through neurogenic shock here before I completely lose my voice. So, neurogenic shock, they call it a hemodynamic phenomenon. And basically, we're talking about the spinal cord. It can occur within 30 minutes of a spinal cord injury at T5 or above. And you're going to have this massive vasodilation. You're going to have pooling of blood in the vessels, obviously the hypoperfusion, like we're going to see with all the shocks, and same impaired cellular metabolism. This can last up to 6 weeks. This can also happen with spinal anesthesia or certain drugs. So just another one of these little pathomaps for the neurogenic shock, and we're going to go over most of this, but just so you have it in picture form. So first you see that loss of the sympathetic tone. You see the vasodilation, which is then going to decrease blood pressure, decrease venous return, stroke volume, cardiac output, cellular oxygen supply, tissue perfusion, and then you have the impaired cellular metabolism. So once again, very, very similar as far as the manifestations. So once again, we have the hypotension, bradycardia, and that's, due to the vasodilation that we're seeing. At first, you're going to see that a patient's skin might be warm due to that vasodilation. But then after a while, they're going to have less ability to regulate their temperature, and they're going to, that term of trying to, or their body just takes on the temperature of the environment. You will see that with neurogenic shock at times. I think that's about all that we will mention about the neurogenic shock. I think maybe I already said this. You can see it as early as like 30 minutes after a spinal cord injury, and then it can last up to 6 weeks. Yeah. Okay, anaphylactic shock. This is obviously an acute life-threatening hypersensitivity allergic reaction. So one of the big things to know is just that massive vasodilation. So I know you guys know, this. This is often due to like drugs, chemicals, can be vaccines. Obviously we have like the food, all these allergies, the peanut allergies that people have, the insect venom, all kinds of things that can cause anaphylactic shock. And as far as the manifestations. You're going to see anxiety, you're going to see confusion and dizziness. Those are kind of some of the initial ones. You may see this sense of impending doom, chest pain, incontinence. I mean, there's so many. Obviously, a lot of people have um, respiratory issues. People are going to have even abdominal pain, cramping, diarrhea, nausea. Um, Back to the respiratory, you're going to see like wheezing and stridor. You may see like flushing of the skin, uh, angioedema. So many different ways that this can manifest with the anaphylactic shock. And obviously, just like in all of them, very important to get medical treatment quickly. Some of the things that you might look for, um, swelling of lips and tongue. You're gonna, like I said, hear that wheezing or the stridor due to the edema. I think I mentioned all the rest of that. Uh, yeah, there is some lab values in the textbook also, um, for I'm trying to look and see what page it was on for you guys. Um, for the anaphylactic shock. Oh, I don't see it, but oh, yes. I guess it's still table 42.2. It kind of talks about the different types of shock that go with each lab value. So it's the same table I mentioned earlier, but just might be a good one to peek at. Okay, so septic shock. So basically, this one, we are focused on the systemic inflammatory response to some kind of infection. So severe sepsis, the main thing you're getting to is the organ dysfunction. You're kind of starting with the hypotension, and that hypotension is often not able to be fixed with fluid resuscitation. That's one of the first things that you try. It's one of the, first things in the algorithm that the ED will have regarding sepsis, but sometimes the fluid resuscitation doesn't always work. So once again, you have the inadequate tissue perfusion resulting in hypoxia. I'm not sure why I have a blank slide here, but so the patho of septic shock, we have a little bit more complicated here, and I'm not going to go over all of this. I don't think there's probably a ton of this that you need to really know, but when you get down to kind of that level, let me see if my mouse will work. I wouldn't worry about too much of this stuff, but basically we're kind of looking at the manifestation. So we as a nurse know what to look for. So we talked about the vasodilation. We have the increased capillary membrane permeability. So back to that picture a little ways back, that would kind of apply to this one as well. So basically, the body's not able to distribute the circulating blood volume appropriately. So once again, we have the decreased cellular oxygen supply, decreased tissue perfusion, impaired cellular metabolism. So manifestations, a little bit different sometimes than the other shocks that we've talked about. So you may see this increased coagulation, and you're definitely going to see inflammation. You're going to see decreased urine output. You are going to see tachypnea, hyperventilation. Ultimately, if it's not corrected, that's going to result in respiratory alkalosis. And then respiratory failure develops in a lot of these septic shock patients. They are going to have altered neurologic status. You're still going to have a lot of that GI dysfunction that you'll have with the others. You might see GI bleeding, you might see ileus. And it's an emergency, just like the others. Sepsis is a big deal. just once again, pictures to kind of help you remember. So you may see shivering. You may see a patient feeling cold. They may have pain, they may not. A lot of times their skin is pale, or sometimes they'll have some kind of a rash. They're extra sleepy. Once again, that sense of impending doom, and then short of breath. So obviously, we're taking care of them once they're already in the hospital at this point. But um, oh, let's go back. So I think we'll stop at septic shock for now. I'll try to get the rest of your lecture recorded tomorrow morning for you, but I think I'll go ahead and post this part in case you want to start listening to it. Let's make sure I didn't want to note anything else about septic shock. Um, you might want to think a little bit through how the ejection fraction kind of fits in here. So it's going to be decreased at the beginning of septic shock. And the ventricles are going to have to dilate to maintain your stroke volume. And then obviously we see the repercussions of that. But sorry, your ejection fraction does typically start to improve over, the next 7 to 10 days. And then you sometimes will have higher CO and lower stroke volume as things progress. So that's why you have the hypotension. And then another thing that will differentiate the septic shock is that I'm trying to think of the best way to say this. Your coronary artery perfusion and myocardial O2 metabolism. I'm literally just reading from the book because I can't think of a better way to state this, but they're not altered as much in septic shock as you'll see in some of the others. So you're going to see a lot of the respiratory failure. You're going to see a lot of like compensating with trying to fix or causing the respiratory alkalosis, trying to fix the other issues, and then they cause the respiratory alkalosis. So that's why respiratory failure is so common in patients with sepsis. And often these patients will end up needing to be on a ventilator. So, I mean, it's similar to the others, but it's the one that's probably the most different in that respiratory piece and just the coronary artery perfusion piece that goes along with it. So let's see. I think that's pretty good. So we will go over obstructive shock once my voice recovers or in the morning.